by the intercommunication. It is formed by the intercommunications among the anterior primary rami of the lower four cervical nerves C5 till C8 and the first thoracic nerve T1 and provides the sensory and the motor innervation of the upper extremity. It is divided proximally to distally into rami or roots, trunks, divisions, cords, and terminal branches. It is responsible for the motor innervation of all the muscles of the upper extremity, and the trunks can be found within the posterior triangle of the neck between the anterior and the middle scalenine muscles. So this is a diagram that is depicting the brachial plexus, how the brachial plexus that is mainly formed with the C5 and C6, which is forming the superior trunk, then leading into the anterior and the posterior, forming the three cords, that is a lateral cord, posterior cord, and the middle, which is giving the terminal branches. All this will be discussed in the later part of the. This is again the small diaphragmatic representation showing what all blocks that can mainly be given at what all positions. That is interscalene that can mainly be given at the root levels, supraclavicular at the trunk levels, and the division, the cords, infraclavicular or the costoclavicular block, and the terminal branches. We can give the axillary brachial plexus block. The embryology, the motor nerve fibers found in the brachial plexus that arises from the cells within the basal plate of the developing spinal cord and emerge to the ventral nerve roots. There is a sensory fibers found in the dorsal nerve roots originate from the neural crest cells. The dorsal nerve root will grow towards the ventral nerve root and eventually join to form a spinal nerve. This spinal nerve will divide into the dorsal primary rami and the ventral primary rami. As the limb bud develops, the nerve will elongate and grow into the limb into the dermatome and the myotomal distributions. The architecture of the brachial plexus. So it is divided into the five divisions. So we'll be going on with the first one, that is the roots. The ventral rami of the spinal nerve C5 to C1 referred to as the root of the brachial plexus. This spinal nerve roots that mainly results as a ventral nerve rootlets originating in the anterior horn cells of the spinal cord and the dorsal nerve rootlets that join in the spinal ganglion in the region of the intervertebral foramen. These roots emerge from the transverse process of the cervical vertebra immediately posterior to the vertebral artery and travels in the cephalocaudal direction to the transverse foramina. Each transverse process consists of the posterior and the anterior tubercle, which meet laterally to form a costo-transverse bar. So this is the USG image that is mainly depicting the various transverse processes. There are the anatomical structural landmarks which helps in the actual identification of the roots. There is the C5 transverse process, C6 and C7. We can just identify by scanning it. The transverse process, they are mainly found at the junction of the lamina and the vertebral pedicles. The deep cervical artery leaves the neck proper and enters the nape of the neck, passing between the transverse process of the C7 and the first rib. The transverse process of C2 to C6 have a similar appearance, being a U shape with an anterior and a posterior process. The C6 is having a prominent anterior tubercle, whereas a shorter posterior tubercle, also known as a chasignet tubercle, whereas the C7 that is having a prominent posterior tubercle with an absent anterior one. We can make out from the ultrasound image depicting here with a prominent posterior different transverse processes which we have captured at our institute. Here it is the C5, the transverse process that is having posterior tubercles of the similar height, whereas this is the C6, the transverse process that is having the prominent anterior tubercle of the chasignet tubercle, whereas the C7 transverse process has a shallow anterior tubercle and the vertebral artery is medial to it. Second, we'll go on to the trunks. Shortly after emerging from the intervertebral foramina, five roots C5 to T1 unite to form three trunks. The trunks of the brachial plexus passes between anterior and the middle scalene muscles. The ventral rami of C5 and C6 forms the upper trunk. The suprascapular nerve and the nerve to the subclavius arises from the upper trunk. The suprascapular nerves contribute the sensory fibers to the shoulder joint and provides the motor innervation to the supraspinatus and the infraspinatus muscles. The ventral rami of the C7 continues as the middle trunk, and the ventral rami of the C8 and T1 unite to form the lower trunk. Divisions. Each trunk splits into the anterior division and the posterior division. The anterior division usually supplies the flexors as well as the posterior usually supplies the extensors, cords, After the divisions, they are usually there is usually the formations of the chords, which are referred to as a lateral, posterior, and the medial chord according to their relationship with the axillary artery. These chords pass over the first rib close to the dome of the lung and continue under the clavicle immediately posterior to the subclavian artery. So this is actually the different nerves which are supplying the different muscles. That is the nerve to the subclavius as it is supplying the subclavius muscles, the dorsal scapular nerve, the long thoracic nerve, the suprascapular nerve, the thoracodorsal, axillary, the musculocutaneous, and the medial and the ulnar nerves. These are actually the muscles which are supplied by these nerves of the brachial plexus. The nerves originating from the brachial plexus. From the roots, the two nerves they are actually originating, which is a dorsal scapular nerve and the long thoracic nerve. At the trunk level, other two nerves originates, which is the suprascapular nerve and the nerve to the subclavius. There is no nerve originating from the division levels. At the cord levels, from the lateral cord, the lateral pectoral nerve and musculocutaneous nerve and the median nerve is getting originated. From the medial cord, the medial pectoral nerve, the median cutaneous nerve of the arm and forearm, and the ulnar nerve. And the posterior cord has a superior and the inferior subscapular nerve, the thoracodorsal nerve, the radial nerve, and the axillary nerve. Nerves originating from the brachial plexus, from the roots. Now we'll talk in detail about the all the nerves. From the root level, the dorsal scapular nerve and the long thoracic nerve. The dorsal scapular nerve originates from the rami of the C5, whereas the long thoracic nerve originates from the rami of the C5, C6, and C7. Both the nerves they are often observed piercing the middle scalene muscles. The long thoracic nerve innervates the serratus anterior muscle and travels with the lateral thoracic artery, whereas the dorsal scapular nerve innervates the levator scapulae muscle, rhomboid major and the minor muscles, and may travel with the dorsal scapular artery. There is also the contribution from the C5 root to the phrenic nerve. Now, these are some of the ultrasound images which is depicting the dorsal scapular nerve as well as the long thoracic nerve. So here in the black arrow on in the first image, we can see the dorsal scapular nerve, which is emerging from the C5 anterior ramus and piercing the middle scalene muscles. Whereas in the photo with the white arrow here, we can see the long thoracic nerve, which is also associated with the middle scalene muscles. The suprascapular nerve here with the yellow arrowhead, which is a branch of the superior trunk of the brachial plexus, which we can see in the image number D. From the trunk levels, the suprascapular and the nerve to the subclavius originates from the superior trunk and contains the spinal levels of the C5 and C6, while the inferior and the middle trunks are devoid of the branches. The suprascapular nerve travels to the scapular notch to provide the innervation to the supraspinatus and the infraspinatus muscles. There are no branches from any divisions of the brachial plexus. Majority of the branches of the brachial plexus arise from the cords. So we'll discuss about all the branches of the originating from the cords, branches from the lateral cord, which is the lateral pectoral nerve. The lateral pectoral nerve is formed by the fibers of C5 to C7. It crosses the axilla deep to the pectoralis minor muscles and penetrates the deep surface of the pectoralis major muscle, which it innervates, and in the addition, it innervates the acromioclavicular joint. The second one is the musculocutaneous nerve. It is formed by the fibers from C5 to C7 and it pierces the coracobrachialis muscles and it descends between the brachialis and the biceps brachii muscles. At the elbow, the musculocutaneous nerve becomes the lateral antebrachial cutaneous nerves and descends along the superficial surface of the brachioradialis muscles, innervating the skin covering the muscles. In addition, it also innervates the humerus, elbow, and the proximal radio-ulnar joint. The last one is the median nerve. The median nerve is formed by the junction of the branches of the lateral as well as the medial cords. So en route, this median nerve that it is anterior in the image we can see it is actually anterior to the axillary artery and then it becomes lateral and then it crosses the brachial artery medially and then it runs on the top of the coracobrachialis muscle and whereas the brachialis muscles and at the elbow level it is under the bicipital aponeurosis and then later on in the forearm, it comes between the flexor digitorum superficialis and the flexor digitorum profundus. And then later on, it divides to form the medial as well as the lateral terminal branches. The common palmar branches divides into the proper palmar branches that innervates the skin of the thumb, index, middle, and the ring, the lateral half fingers. This innervation covers the palmar surface as well as the nail beds. The motor innervation is to the most of the flexor muscles in the forearm and the intrinsic muscles of the thumb, the thin arm muscles, whereas the sensory innervation is to the lateral, the radial 3.5 digits, that is the thumb, index finger, and the middle fingers, as well as a half of the ring finger. Now we'll talk about the another cord that is the branches from the medial cord, the medial pectoral nerve, which innervates both the pectoralis major as well as the pectoralis minor muscle. There is a medial brachial cutaneous nerve innervates the median side of the arm. There is a median antebrachial cutaneous nerve, it innervates the median side of the forearm. The C8 to T1 ulnar nerve is completely formed by the medial cord. As we can see here from the shoulder, it exits from the brachial plexus and medially to the axillary artery by the median cord, and then it traverses over the coracobrachialis and through the intermuscular septum. It passes close to the median head of the triceps. At the elbow level, it is behind the medial epicondyle, and it then travels towards the heads of the flexor carpi ulnaris. Then later on, it goes under the flexor carpi ulnaris, and then laterally on the top of the flexor digitorum profundus. And then later on, it gives the superficial sensory branches as well as the deep motor branches. It branches into the superficial branch and the deep branch in the hand. The superficial branch, it innervates the palmaris brevis muscle and provides a sensory to the palmar surface of the little finger and the median half of the ring finger. Whereas the deep branch of the ulnar now provides a motor innervation to the muscles of the hypothenar and the adductor interosseous compartments of the hand. The branches of the posterior cord. There is one is the suprascapular nerve. It supplies the upper, middle, and the lower subscapular nerves. Second one is the axillary nerve. The third one is the radial nerve. The radial nerve at the shoulder level, it is posterior to the axillary and the brachial artery, and via the profund and along with the combination with the profunda brachii artery, it forms a spiral groove around the humerus, and through the lateral intermuscular septum it passes between the brachioradialis and the brachialis level, and then it terminates over the lateral epicondyle, giving the superficial radial nerve and its terminal branches. And the last one is the thoracodorsal nerve, which is formed by the fibers of the C5 to C7. So this is the cutaneous innervation of all the nerves, which is mainly supplying the upper limb. And this is the dermatomal innervation, which is mainly supplying. We can see here in the image the variants. One of the most common variants of the brachial plexus is the contribution from the C4 and T2. The contributions from the spinal cords level can vary. For example, a branch of the C4 can be small, while the branch from the T2 can be large. Even with this typical levels involved in the formation of the brachial plexus, the levels present in a given nerve can vary. This can lead to the variation in a dominant innervation to the muscles or the variation in the dermatomal distribution. Now, how to scan? This is the ultrasound scanning for the brachial plexus. This is also called as a sequential ultrasound imaging technique. We can a sequential scan over the 7 contiguous sites. First, we'll keep the probe at the supraclavicular fossa and we'll visualize the trunk and the divisions. And later on, while coming with a tilt, and we should come in the cranial direction, and we can start finding all the transverse processes. First one will get the C7 transverse process, and then later on we can find the C6 transverse process and the root arising from it, whereas we can find the C5 transverse process and the root arising from it. So this imaging feature that has to be followed. So here this is the ultrasound scanning of the brachial plexus. So here we are keeping it on the supraclavicular fossa, and we can visualize the trunks and the divisions here. And then we are coming cranially, and there we can see the superior trunk. There is a subscapular nerve, and the posterior and the anterior divisions. And then later on coming, we can see in the picture here, this is the C5 nerve root formed here. C5, C6, and C7 nerve roots between the anterior and the middle scalene muscle. And here the vertebral artery that is medial to it. So now we can see the posterior. This is the C7 with the prominent posterior tubercle. And now we are able to see the C6 transverse process. This is the C5 transverse process. The C5 now root emerging out of the transverse process. Now the C6 is coming outside. This is the C7 that is coming outside here. You can see the vertebral artery that is medial to it. Okay, that's all. Thank you.
Nice. Hello. Nice
Hello. Yes, sir.
presentation, Vishal.
Thank you, sir.
Uh, when can you stop sharing the screen
Yes, sir.
uh, and switch on your camera?
Yes, sir.
Everyone can you please switch on your camera so that we can interact? It doesn't look like we are talking to laptop. Request to all. Okay. So Vishal,
Yes, sir.
we start from interscalary region, right?
Yes,
So
sir.
when we interscalary block, what is the most feared complication?
Sir, this is the phrenic nerve palsy, the most common and
So,
the most fear complication.
anatomically, where it lies, why we are fear about phrenic nerve palsy with interscalary block.
Sir, because it is in the close proximity with the anterior scalene muscles as it transfers over it. So at that level where we are giving the block between C5 and C6 in the interscalene this thing groove, so it lies very close in the proximity of that muscle. So while giving the larger volumes or something, this struck can spread to the phrenic nerve and it can result into the this diaphragmatic paralysis and all.
And how much is that larger volume?
Sir, more than almost 20 ml, sir.
Okay, so if you give less than 20 ml, there are less chances of phrenic nerve palsy. Am I right?
Yes, sir. Around 15, 12 to 15 ml are less chances. If the volume is lower, there's a less chances.
Anyone have any difference of opinion? Hello, you can unmute yourself and
More than five,
more than five. What then? What happens if you give more
uh,
than five? Then
phrenic nerve paralysis incidence goes significantly up.
yeah. So what is minimum volume for interscalary block? Minimum required volume.
Sir, minimum effective like MEV 50 is around, I think, as
0.8 ml.
Yeah.
no,
In the end of expert, even with 5 to 7 ml of LA, you can block the, at the level of interscalary block, you can give the block. But even with that, there are chances of phrenic nerve palsy. Drug may spread to the phrenic nerve and you will have phrenic nerve palsy. So are you afraid of phrenic nerve palsy in all patients, Vishad?
Uh, Not all of them, sir, but majority.
So when you want to avoid phrenic nerve palsy, in which patient?
Sir, in whom the chest, this chest,
Yes. So
the
in
chest is
respiratory
bad and the
papers.
respiratory any complications are there in the patients. They will avoid these things.
Right. So in those cases, you want to avoid phrenic nerve palsy, right? So what
Yes,
are
sir.
the other techniques to prevent phrenic nerve palsy? What are the other blocks by which you can prevent the phrenic nerve palsy?
Sir, we can actually go for the superior trunk block.
Anything else?
We can give subclavian perivascular block, sir.
Okay. Anything else? So you told that shoulder is supplied by which nerves
Suprascapular now, sir. Majority of that
and any other nerve?
axillary.
Axillary, very good. What are the other nerves which supplies the shoulder? Can anyone else tell the now supply of the shoulder? Puja, you can unmute yourself. You unmute yourself. Yeah, now you can speak.
So suprascapular nerve, subscapular nerve, axillary nerve, and lateral pectoral nerve.
Very
So
good.
according to the quadrants, like posterior superior quadrant, it's supplied by suprascapular. Posterior inferior quadrant is supplied by axillary nerve.
Okay,
Anterior inferior quadrant by axillary and lateral pectoral, and
good.
antero superior quadrant by nerve to sorry suprascapular and
Okay. So what is the cutaneous innervation of shoulder, Vishal? You showed the dermatomes, right? So
Yes,
what
sir.
is the, yeah, so what is the cutaneous innervation of shoulder? Which nerves you will like to block for shoulder surgery?
So first one is the suprascapular nerve. Then we'll go
No, for cutaneous innervation.
for the cutaneous innervation, na sir. Uh,
Can you open that image? Start sharing
yes,
the
sir.
screen
Sure.
again.
हाँ sir. This is the
Please share
intercostal
this.
break.
Yeah, please
Yes,
share
sir.
the
One
screen.
second. One
Yeah,
second, sir.
yeah. So you can see the upper area. You can see the
Sup
area. Lateral area is supplied by which now?
Sir, lateral area that is axillary nerve and this supraclavicular nerve and the
So,
intercostal.
is supraclavicular now is it the branch of brachial plexus or something else?
Cervical plexus, sir.
Cervical plexus, sir.
Yeah. So, what is exactly superficial, deep, or intermediate cervical plexus? It is branch of superficial cervical plexus.
Cervical
Super.
plexus.
Do you know about the scut block? SCUT,
yes,
scut block.
Yes,
Yes, sir.
sir. Yes, sir.
yes,
So,
sir.
what is that?
Supraclavicular upper trunk block.
Upper trunk.
Superficial cervical
Cervical
plexus block
plexus,
along with the upper trunk
With
upper
block.
upper
trunk
trunk.
blocks. So, what is the advantage? Which
The
nerves you
phrenic
block?
nerve sparing.
Sir,
Very
phrenic
good.
nerve
Very
sparing along with we can give the block at the posterior border of the sternocleidomastoid as well as we can block the upper trunk also, both of it, sir. So superficial cervical plexus also will be covered as well as the upper trunk will also be covered.
So, what are the chances of phrenic nerve palsy with upper trunk block? There are chances. So, we don't know exactly what are the chances because it is a newer block, but still
Yes.
it can block the phrenic nerve if you give higher volume. If you go like 10, 15 ml of ALA, it will definitely block phrenic nerve. So, be careful, especially in patient with phrenic nerve palsy. So, suppose if you have given interscalene block, how will you assess the phrenic nerve palsy?
Sir, firstly, sir, we just have to put a SpO2 and check for the this thing oxygen saturation of the patient. And later on, if something is happen, if something breathing or the respiratory problems are happening, then we can just turn on the oxygen and we can just ventilate the patient first, and
No,
then we
no.
can even
How will you diagnose first?
we can
What
diagnose it
happens?
by the USG also, sir.
How?
Sir, by place the diaphragmatic function, sir, we can assess it.
What is that called? Can anyone tell?
We'll do it in M mode, sir.
Yeah, that is fine. But what is it called?
You see the sliding movement of the diaphragm.
Diaphragm,
Lung sliding. Di-
diaphragmatic
di-
excursion.
Excursion,
excursion.
yes.
Yes.
All right. So
Yes, sir.
you have to scan preoperatively diaphragm, then you assess it postoperatively after giving the block. Then only you know that there is some variation in the function, and you can diagnose the phrenic nerve palsy. And at the time of assessing the diaphragm on the same side, you can see the diaphragm on the other side
Other
also,
side.
right? So with
Yes.
ultrasound, you can diagnose. Clinical symptoms are difficulty in breathing.
Breathing.
SpO2 will definitely fall, but initially patient will complain of difficulty in breathing. So reassure the patient if it is unilateral block, there is no problem. If patient has a respiratory cripple, the respiratory problems, COPD, then patient will have some difficulty. You have to supplement it with oxygen. Sometimes you require intubation in case of patient has more difficulty in the respiration,
Breathing,
right?
respiration.
Yeah.
Yes, sir.
Now regarding interscalene block, you told some nerves are getting out of the brachial plexus at the level of trunks. Which are those nerves?
At the level of trunks, sir.
Trunks, yes.
Sir, 1 second. Sir, at the level of the trunks, suprascapular nerve and the nerve to the subclavius, two nerves are getting off.
Dorsal scapular, long thoracic nerve. So as you showed in the
Roots.
image,
Yes.
ultrasound image, it comes in the way. In which muscle it travels?
Sir, in the middle scaly muscle, sir.
So suppose when you are giving interscalene block, how will you take care of these nerves? And what happens if patient, if you, damage the nerve?
Sir, it might cause the winging of scapula in case of damage to the long thoracic nerve. If it is,
Okay.
as it is supplying the serratus anterior.
So how will you prevent it? You read it afterwards. This question can be asked. That's why I'm asking. So how will you prevent it? One technique you told, you locate the nerves on ultrasound and you prevent
Yes,
injuring it, right? What
yes,
is the
yes, sir.
other technique? Can you use PNS?
Yes, sir. We can use along with it.
Yeah, so you have to use PNS when you are not sure about dorsal
Sure.
scapular nerve or long thoracic nerve. You use the PNS. You will stimulate the respective muscle, and you will come to know that whether you are stimulating the nerve or not. So that is how you can prevent the nerve injury, right?
Yes, sir.
So now we go at the level of supraclavicular area, right? Anyone from the faculties? Any question from the? I don't know who is showing. Let me check. Dr. Neeta, ma'am. Dr. Neeta, ma'am, any question from your side?
Inadvertent structures that are pierced while you go in plane, whether this was covered in between I had lost connection. Was this addressed?
We talked about dorsal scapular nerve and long
Long
thoracic
thoracic.
nerve.
Yeah, and if you were asked whether you would prefer an in plane or an out of plane approach?
Ma'am, out of plane approach, we won't be able to find all this nerves. Whether if we go in plane, we'll be able to visualize and locate this.
No, nerves you can see with in
You
plane or
cannot
out
see
of
the
plane.
needle.
Yeah, it is about needle visibility, right?
We won't be able to see the needle. Yes, in out of the plane.
So what is the difference between in plane and out of plane?
Sir, in the visualize the whole of the needle, whereas in out of the plane, the whole needle won't be visualized for.
So how will you locate the needle with out of plane technique?
So just the tip will locate, sir.
So how will you locate exactly the needle tip with out of plane technique? Have you given out of plane block, any block with out of plane technique?
No, sir, not much of it out of
So
plane.
when you want to give out of plane block, you have to move the probe along with the needle tip. So you have to keep the needle tip always under vision. Shaft and needle tip will look similar. So always move the probe as you advance the needle, and you have to go perpendicular to the skin so that you see the needle tip. Another thing you can do is hydro dissection, right? So you
Dissection.
can inject small dose of saline so that you can know where your needle tip is, and you can prevent injuring the vital structures around the plexus, right? Neeta, ma'am.
Okay, sir.
If you want to prolong analgesia, what are the options that you have? It is say
Ma'am,
it's a shoulder replacement, and you want to prolong analgesia for this patient.
okay. We can use a continuous catheter techniques, ma'am.
Okay.
We can
Then
usually put a
how will you place it? In plane, out of plane?
ma'am,
Any
in
tips?
plane. In plane we have done, ma'am. So we'll just hydrodissect first, and we'll just locate where our needle tip is, and then we'll put the catheter along that thing, and then we'll just hydrodissect whether the drug where it is spread, the drug spread will check, and then later on we'll just fix it.
Yeah. So with regards to catheter insertions, even since the out of plane, the plexus is barely half a centimeter below. So with experience, definitely, and knowing where the vital structures are, out of plane is practiced by quite a few experts. One thing, you should be able to justify it if you have done it. Only interscalene and femoral block are the two blocks which can be considered to be given out of plane with all the safety precautions that are taken for the block, like pressure injectors, needling with,
Yes,
you know,
pressure.
making sure that you scan with the needle as you progress. And it's hardly half a centimeter. It's a very superficial block, especially the interscalene.
Okay, ma'am.
What about
मानविका मॅम पण
adjuvants?
नव्हत्या का आज?
Adjuvants?
म्हणजे त्या
Sorry.
नव्हत्या गेल्या ना, सदर मॅम गेल्या होत्या ना फक्त.
Adjuvants.
Adjuvants, ma'am, we can use dexamethasone, we can use clonidine
अगं
Abhishek,
अगं
for
can you please mute
Evidence?
yourself?
for prolong.
Abhishek, can you please mute? Yeah, please.
Is there evidence to state that it will, it is beneficial? Clonidine and dexamethasone. What do studies say?
Ma'am, they are actually prolonging the duration of the block. Some of the articles they are saying that.
So out of play, sorry, if what I'm asking is IV dexamethasone versus in the block, is there some real benefit?
If you
Have you
compare
gone?
IV, yeah, if you compare IV to
Is it recommended? FDA approval is there for giving it in the block? You got my question? You got the question?
I got it. Yes, yes, yes.
So apart from
Ma'am, I'll just check it.
yeah, you check it up. Apart from these, you'll have to keep ready. You'll have to go through the prospect for the shoulder joint as well.
Yes,
The
sure.
prospect studies as
Okay.
to what is the way forward. You must mention multimodal.
Yes.
You can mention transdermal patches, provided you have used and know when to put it.
Oh.
Yeah, because single shot will give.
Yes.
And I'll just say, how long does your interscalene, the block you give, last?
Ma'am, 12 hours, 12 to 14 hours, max to
Right.
max.
And like rotator cuff repairs and all, they're quite painful surgeries.
Yes.
So they would warrant
So,
long duration.
yes, ma'am. Yes, ma'am.
Yeah, any other questions you can ask?
anyone else?
Good evening, Vishad. Just a suggestion. When we
Yes,
read
ma'am.
about anatomy of brachial plexus, try to read about the variations. Okay, I have just
Yes,
shared
ma'am.
in the group two articles of RAPM which are very beautifully written. So
Okay.
it is difficult to cover in a single session about anatomy totally. So I've just shared the articles. Kindly go through it, and
Sure.
the traffic light sign and all. It is very nicely explained. So just go through those articles. I think it will help the other fellows also. Okay, so
Sure,
variation,
ma'am.
whenever we talk about anatomy of brachial plexus, the variation also comes in place. Okay.
Yes, ma'am.
Vishad, you told about contribution from C4 and sometimes T2. So what is it called? There is specific word for it. Do you know it?
No, sir.
Prefix
Yes,
and
sir,
post.
it is
Yeah,
prefixed
please.
and post. If C4
Yeah,
contribution is there, then it is prefix. If prefix and postfix. Yes.
very good, very good. Another question to you, Vishad. Suppose if patient is has some respiratory problem, you are doing under general anesthesia, you don't want to block phrenic nerve. So what individual nerve will you block while giving to provide analgesia?
For
Which
shoulder
indi-
surgery, sir?
Yeah, for shoulder surgery.
Okay. Uh, So the same things will be blocking the suprascapular nerve, then will be
Where
blocking the axillary nerve.
where will you block suprascapular and axillary nerve? At which level? Do you know it, Vishad? I think it is. Hello, Vishad.
For the
Can you
shoulder,
hear
sir?
me? Yeah, for
Yes, sir.
shoulder.
Hello, sir. Yes, sir.
Yeah,
Yes.
yeah. Now I can hear you.
Sir, the same ones, the suprascapular.
That is fine, but where you block it? Pooja, will you like tell?
Surgery, we need to
Sir,
cover
we
them
can
up.
block we can block the lateral pectoral
Hello.
nerve and subscapular nerve below the coracoid process in subscapular plane, and we can block the lateral pectoral nerve in pectoralis major and pectoralis minor subscap. So
Where will you
below
block
the
suprascapular? Suprascapular.
sir, I will block suprascapular in as much as low in the above the supra in the supraclavicular fossa, but as much low I can see the suprascapular nerve. I will block. Otherwise, the
And
anterior and posterior approaches are there for the
so
suprascapular nerve.
where is the posterior approach? What is the posterior approach? Vishad, Pooja,
Sir, we
anyone
can
else?
just block it before it is getting separated from the anterior as well as the posterior divisions. So once it is there in the upper trunk, we can go and block it there.
That is fine. But there
Yes.
are chances of phrenic nerve palsy. So if you want to block suprascapular nerve separately, there are two approach, anterior and posterior, right?
Posterior.
So what is anterior approach and what is posterior approach?
Sir, anterior approach is intraomohyoid anterior
Very
suprascapular
good,
nerve block,
very good.
and uh, sir, posterior. I need to read about posterior.
Yeah. So where this now suprascapular nerve travel in the posterior part? Vishad, any notch?
Uh,
Yes.
s-
Suprascapular notch.
Suprascapular notch,
Suprascapular
sir.
notch.
Scapular notch.
Very good. So you can either block in the suprascapular notch or below the omoid muscle where it
Omohyoid muscle.
where from where it goes posteriorly towards the suprascapular notch. So even if you are giving 4 ml of LA in the with entry approach, there are some chances of phrenic nerve palsy. There are reports of phrenic nerve palsy, but when you go posteriorly, there are zero chances of
Zero
phrenic
chances.
nerve palsy. And axillary nerve, you have to go posterolateral to the shoulder, and you have to find the axillary nerve below the deltoid muscle,
Deltoid
and
muscle.
you have to block. So please read it
Yes,
because
sir.
these questions can be asked during your
Yes,
examination.
sir.
That's why, right? So
Yes.
when you are giving a supraclavicular block, which is the nerve commonly spared?
Sir, ulnar nerve.
Ulnar nerve. Why?
Sir, because it is originating from the inferior trunk, so it is there. So we'll just have to go and block the. We'll just give a corner pocket injection first, and we'll
So
go and block the ulnar nerve.
what is corner pocket anatomically?
Sir, from that anatomically,
Where does it lie?
The corner pocket is between the first rib and the subclavian artery.
subclavian
Very
artery.
good, very good. So you have to go at the angle between subclavian artery and the
Artery and the first
first inject drug there, then go for middle and upper trunk.
upper
Right?
trunk.
Right?
Yes, sir.
Anything you want to ask Nita ma'am in supraclavicular? Nita ma'am?
If there is an evidence of both the shoulder injuries, I had a frozen shoulder of the patient, both the shoulders are frozen, and they want to request in the similar setting. Can you give bilateral interscalene, or are there any options?
Bilateral interscalene, ma'am.
Are you confident that the phrenic will not get blocked? And You'll take care of it.
No, ma'am.
Okay. So it's safer to say that you won't do it because
Yes.
you can say that it's a learning curve till I gain experience in
Gain experience.
getting an absolute phrenic sparing block. Yeah.
Yes,
So
ma'am.
it's better to be safe than that. We tried different combinations of suprascapular and axillary individually.
Yes.
So do you know how the suprascapular and axillary are individually blocked? Are you aware?
Ma'am, suprascapular I'm aware, but axillary we haven't tried actually, ma'am.
But do you know what is the course of the axillary nerve? How does it travel and where can you block it? You heard
Ma'am.
about inferior
Hello.
Ma'am, we are not getting your voice.
capsule, anterior-inferior capsule. Yeah.
Yes, ma'am.
There are various approaches.
Yes.
Have you heard of Harman-Hardy approach to the suprascapular block?
Ma'am, no, actually. I just need to read about it, ma'am.
Yeah. So individual nerve blocks also, there are at least 3-4 approaches to axillary from posterior as it comes out from the quadrangular space. Those should be known.
Okay.
If I have to last ask you to summarize in 5-6 points, how will you spare phrenic? You spoke about you can do a diaphragmatic assessment to know whether phrenic is blocked or no.
Okay.
What are your prevention strategies?
Prevention strategies. Ma'am, we'll just firstly locate the phrenic nerve on the ultrasound,
Very good.
where it is and where it is originating from and how the course is going. So first we'll locate it and then we'll
Yes, that is one approach. What else? Locate and stay away from it as much
stay away from it as much as possible.
What else?
Bit visual.
You discuss these points, I suppose. How else?
Ma'am, then the lower volume of the drug will be given.
Yes, very good. What else?
Does concentration of drug affect?
Less concentration will be this thing
Is it
because the more
concentration or is it volume?
Ma'am, volume will matter more because the spread will be.
If I give 0.75 and I give only 5 ml, is that
Yes.
important or giving 20 ml is important?
20 ml, ma'am, that will go and
That
easily
is volume.
Volume.
Of course, dose should be the dose which is enough for surgical anesthesia.
Enough for surgical anesthesia.
Right?
Yes, ma'am.
What else? So you said locate phrenic.
Avoiding the larger volumes. And,
these points should be pit pat. Yeah.
Yes.
Lower in the groove will help.
Yes, ma'am. It might because in the upper groove it will be in the upper part to the phrenic nerve will be
more closer to the roots, right? To the ventral rami.
Yes.
What is the incidence of phrenic nerve palsy with supraclavicular block?
Yes.
Sir, it will be.
Anyone else?
Should know the incidence with each, with costoclavicular, with infraclavicular, with supraclavicular.
In literature, it is 19 to 60%. So roughly it is 50%. Even with supraclavicular nerve block, if you give 20-25 ml of LA, 50% patient will have phrenic nerve palsy. So again, you have to reduce the
Volume.
Right. Anything else?
Even a strategy to stay, if you're going out of plane, a strategy to stay lateral to the ventral rami versus medial. There are many factors. If you go to see, there is pressure of injection. If you give a large volume suddenly, it can easily go over the anterior scalene. And even if you have seen the phrenic, it will unknowingly block the phrenic as well.
Yes.
So the pressure of injection, the volume being lateral to the ventral rami. Yes?
Yes, ma'am.
Even while giving a superficial cervical plexus. Your needle goes in too much, too in below the prevertebral fascia superficial layer. That itself can directly block the phrenic.
Phrenic nerve.
So these strategies you should be able to tell spontaneously, and the ways you will. So there are 3 questions. One is how will you prevent, avoid, identify, and treat? Is there something to treat it? Have
Ma'am,
you heard?
100% oxygenation first thing.
That
If
is,
the
yes,
patient is having the respiratory difficulties or something,
yes.
then later on we can just assess him first, whether what amount of difficulties he's having, the oxygen saturation of oxygen monitoring and all.
Yes. Is there any, you've heard of saline washout? Does it help?
No, ma'am, saline washout.
Yeah. So you can mention, you can read up case reports are there, but it is too primitive or too less number of studies to recommend it as a class or level of evidence.
Okay,
Yes.
yes, ma'am.
That's all.
Actually,
But good.
actually, shoulder surgery will be either it will be your full, I mean, question in theory paper, or it will be your case. So you should know everything about shoulder surgery, like anatomy, what are the approaches, what are the phrenic sparing approaches, how much it will be the volume, what are the incidence of phrenic nerve palsy. All these things should be learned, and it will be
Yes.
asked.
And
Yeah,
one more, just a small suggestion is you should enumerate, speak to an orthopedician about the different surgeries that they perform on the shoulder, and
yeah,
even
Okay,
know about the various incisions. There
yeah,
is lateral
exactly.
incision, anterolateral incision, deltopectoral incision. Where does the axillary nerve exactly anatomically involved with the shaft of the humerus, upper end, at what distance, how many centimeters? All this you should be really absolutely well versed with. If they do
okay,
lateral jet, if they do Bankhardt's repair,
Blanket.
what do they exactly do? Is the, the pain, is it any different for any of these surgeries? If they do a reverse shoulder arthroplasty, so as fellows, I personally feel a little more deeper versus just what the brachial plexus branches, what innervation. There is no one answer to everything.
Yes,
You have to read a little more deeper into this, discuss with your orthopedician who does frequent surgeries, right?
yes, ma'am.
That's all. But good attempt. Nice pre-Diwali. Good attempt. That's nice.
Uh, Now we go below clavicle, right? So you told that below clavicle there will be chords, and they take their anatomical position. But before taking anatomical position, where does they lie, and what is the approach to this area? I mean, medial infraclavicular area.
So lateral infraclavicular fossa as well as medial infraclavicular fossa, the cords will be traveling according to that. So for the lateral infraclavicular fossa, the blocking the cords at that, uh,
At medial infraclavicular fossa, where there's chord lies.
sir, it
What is
is
that approach?
situated.
Yeah,
Sir,
what is that?
it is situated around the axillary artery.
No, no, not around axillary artery. Do you heard about costoclavicular approach to the brachial plexus? What is that?
Yes, sir. So costoclavicular approach, that is a lateral infraclavicular fossa, will be just
No, it is medial infraclavicular fossa. So where does the cord lies in the costoclavicular area? Direct
so
question.
it is lateral to the axillary artery, sir.
Very good. So where does the lateral cord lie? Where does the medial cord lie? And where does the posterior cord lie?
Uh,
Which is the superficial most?
so superficial most will be the lateral one, sir, and the
Hmm.
deeper most will be the posterior one, sir.
Any
Hmm.
difference of opinion? My other fellows are silent. They can speak. Shweta, Sonal, then Samsung, Shyam Sundar, Prachi. Anyone wants to answer that question? Deep.
Yes, sir. Yes, sir.
Yeah, Pooja, you are
Uh,
answering the question, but no one else.
The lateral cord is the superficial most.
Very
Then
good.
the middle cord will be deeper one, which is inferior to the lateral cord, and the posterior cord will be inferior and lateral to the lateral cord.
Lateral
So
Yeah.
cord.
post yes, and all in the one sheath, and the posterior cord and the middle cord will be again in the one sheath, and the lateral cord in the separate sheath. In
So
the whole cords are in the one sheath, but then there is a separate sheath around the lateral cord and
so
between in the posterior cord and the
so
middle cord.
what is importance of that? You told that there
Because
is a
of
set.
that, we have yes, sir. Because of that, we have to give a 2 point injection. We need to give 2 point injection, like
Very good,
not
very good,
one
excellent.
cluster injection. We need two injection points.
So initially we were thinking that with single injection you block all three codes in the costoclavicular area. But then we found that there is a septum between lateral cord and the bunch of
Median and
posterior,
the
the medial
posterior.
cord. Yeah. So if you inject at single level, you either block the lateral cord or posterior and the medial cord. So you have to give injection at two level. So yeah, what is the advantage of costoclavicular block over lateral intraclavicular block?
Sir, it is good for placing the
Sir,
catheters,
Very good. Anything else?
uh,
sir,
but
it is
sir, it can.
difficult to.
Yeah, Vishad, first you tell, then Pooja will tell. Pooja will
Sir, it
explain.
is kind of an advanced block, sir, because it is much more in a relationship with the pleura. So
Okay, it is close to pleura, so chances of
the pneumothorax or the pleural injury is
so
more.
so which approach has highest chance of pneumothorax? Brachial plexus block. Which brachial plexus has highest chance of pneumothorax? Is it interscalary, supraclavicular, costoclavicular, or lateral intraclavicular?
Supraclavicular.
Hmm?
Supraclavicular block, sir.
Vishad, what is your opinion?
Sir, infraclavicular, sir.
No, it is supraclavicular. If
Okay.
you don't know this, then it is really difficult. Everybody should know this, that highest incidence of pneumothorax is with supraclavicular. Why? When you are scanning for supraclavicular, what you see? You see the rib and you see the
First rib
pleura,
and the pleura.
pleural dome, right? So chances
Yes.
of pleural injury is highest. So how will you prevent it?
Sir, by keeping the subclavian artery in a close proximity to the first rib, we can
Very
prevent the
good.
pleural injury, sir.
Very good. Anything else? Is there any difference between out of plane, in plane approach? When you are doing in plane approach, you will see the entire needle shaft and tip all the time, right? So chances
Yes.
of pneumothorax is less when you are using in plane approach, especially when you are a beginner. In the hand of expert, it is same. But when you are beginner, always go for in plane approach. It will reduce the chances. Another very important point which you should keep it in mind when giving supraclavicular block, either with PNS or with ultrasound, always attach syringe to the extension tubing while locating the plexus. So if you accidentally puncture the pleura, it will not suck the air. If it is open to air, it will suck the air and there will be pneumothorax. But
Okay.
if you attach the syringe to the needle or the extension tubing, then there will be less chances of pneumothorax. So always attach needle or extension tubing while locating the plexus, right?
Yes.
Now you were telling about advantages of costoclavicular block over other blocks. What are other advantages? You told about you can put the catheter there. You told that there are more chances of pneumothorax as compared to lateral intraclavicular, right? Or pericoracoid approach. Any other
Yes.
advantage? Volume of the drug, is it higher or lesser?
It will reduce, sir.
It will reduce.
Because they are arranged, the compactly arranged. The cords are compactly
Yeah.
arranged there.
Chances of
So
sparing, chances of sparing,
that is also reduced, sir.
chances of phrenic nerve palsy.
It might be minimal, sir.
If you compare to pericoracoid approach or lateral approach, it is higher or lesser? Pooja, you are muted. It is higher or lesser phrenic nerve palsy when you go for costoclavicular or pericoracoid approach? Obviously, it is higher when
Higher,
you are
sir.
doing
Huh.
costoclavicular
For
because you are close
costoclavicular.
to, yeah, you are close to the
Close
phrenic
Yes.
nerve. When you go laterally, you are away from the phrenic nerve.
away
So
from the phrenic nerve.
there are reports of phrenic nerve palsy even with pericoracoid approach, but it is with a very high volume. And there are there are few case reports only. But with costoclavicular block, there is definite chance of phrenic nerve palsy. And if you scan up in the supraclavicular area after giving costoclavicular block with higher volume, you will see that drug is spreaded cranially as well. So it may block the phrenic nerve as compared to lateral approach. So we have done costoclavicular block. Nita ma'am, any question regarding costoclavicular block? Nita ma'am?
No, sir. No. The
Okay.
incidence of phrenic, anybody has answered? Incidence of phrenic nerve
I asked about
involvement?
higher or lower, not exact incidence because I know that.
Yes, yes. Still,
Okay,
there
so
is a 10% chance.
yeah, so you should
Chance,
read the
depending on the volume
incidence
that
of
is given
exactly, ma'am.
at level, at each level.
Right? Any question till that this? So any question from any fellow? Okay. So we move to the pericoracoid approach, right? So in pericoracoid approach, how will you block the plexus and what is the difference between costoclavicular to pericoracoid? So start with in pericoracoid approach, they take anatomical position, right? Posterior cord lies posterior to the artery, lateral cord lies lateral to the artery, and medial
Lateral
cord
to the
lies
artery and the medial cord like
medial
medial.
between medial artery and the vein. So which
Yes.
cord will you block first? It will be posterior cord, lateral cord, or the medial cord, and why? Okay. So when you are giving pericoracoid, infracoracoid block with pericoracoid approach, it is a deeper as compared to
Yes,
costoclavicular
sir.
area, right? So
Costoclavicular.
yeah.
Yes.
So when you see the angle of the needle, it will be acute angle. So it is difficult to
Yes.
visualize the needle.
Yes.
So always go for the posterior cord first. That will lift up the
Yes.
structure.
Lift up
If
the
Yes.
yes, sir.
structure, right? If you inject the drug around the lateral or medial cord, it will
It
suppress
will
the
go
structure.
again deep down, so needle.
Yeah, needle, it is difficult to visualize the needle. So this is practical tip. Always go for the posterior cord first, then lateral, withdraw the needle and inject around the lateral cord, then
Lateral cord
redirect the
and then
needle
the
toward the medial cord and inject the drug. When you are giving with PNS, suppose, pericoracoid approach, what are the landmarks? Okay, you can read it. I know you must. Actually, it is you have to palpate the coracoid process. You have to go 2
correct.
centimeter lateral, sorry, medial and 2 centimeter caudal. You have to insert the needle, feel the clicks of the prepectoral fascia and interpectoral fascia. Then you will initially get the lateral cord response. What is lateral cord response? Pooja, you can unmute yourself. What is lateral cord response?
Uh, elbow flexion and yes.
And which fingers? Okay, you can read it.
Yes.
PNS guided block, you should know it. It will be asked in the exam. So always read the PNS guided blocks also. So there are two approach, pericoracoid, infracoracoid block. There are many approach, but these are the most popular approach in the infracoracoid. VIB is similar to the costoclavicular, while pericoracoid approach, it is similar in both ultrasound and PNS. And in both the blocks, posterior cord response is desirable because when you
Yes.
inject a higher volume near the posterior cord, it will spread to the lateral as well as medial
Yes.
cord. But if
Medial
you,
cord.
yeah, if you inject near lateral cord, there are chances that medial cord will be spared. Or if you inject near medial cord, there are chances that lateral cord will be spared. So there will be
Spell.
inadequate block, right? Axillary block, it is a simple block. You know it. Which nerves you block at the axillary level?
Sir, the median nerve, ulnar nerve, radial nerve, and the musculocutaneous nerve, sir.
And where does it lie?
Sir, it lies between the coracobrachialis as well as the biceps brachii.
Which nerve?
Musculocutaneous nerve, sir.
Very good. And lateral medial and sorry,
S-
median ulnar and radial nerve, where does they lie?
Sir, they are along with the relations of the axillary artery only, sir. The median radial nerve with the posterior to the artery, whereas the ulnar nerve will.
Radial nerve
Sorry,
lies
sir.
on the which muscle? On the which muscle? Between a muscle and the artery. It is called conjoint tendon, which is formed
Conjoint
by
tendon.
which is
Yes,
Uh,
formed by
conjoint.
which is formed
There
by
is major
series.
and
teres,
there is
teres,
major and
Okay, you can read it. So
short
it is
lattice
always
majors.
lying above the yeah. It always lie above the conjoint tendon and below the artery. And anatomical variation, there are many anatomical variation
yes,
when you go for
vascularity
in
and
the
variation.
axillary area. So you have to be careful. And there are many veins sometimes
Yes,
surrounding
sir.
the artery. So chances of local anesthetic systemic toxicity are higher with
Is high.
axillary block. You have to be very careful. You have to always look the needle tip and look for the spread of the drug.
Yes.
Again, when you are giving with PNS, always stimulate the radial nerve first. You can inject
Yes.
the drug there, it will spread to both, and then stimulate the other nerve. What is Raj stress when you are giving PNS guided block? Read it, right? Distal nerve block, you can give it at the elbow and the below, right? Where does the
Yes.
median nerve lie at the elbow?
Sir, between the flexor digitorum profundus and the superficialis, sir, in between
It
the
is at the
muscles,
mid forearm level. It is at the mid
mid
forearm level.
forearm.
At the elbow,
Yes.
at elbow, where does it lie? It lies medial to the which artery or lateral to the which artery? It lies medial to the artery or lateral to the artery, brachial artery.
Medium to the brachial
Median, sir.
Medial to the brachial artery, right?
Brachial artery.
So either you can block it at the level of elbow or at the level of mid forearm. Ulnar
Mid
nerve,
forearm.
where will you block ulnar nerve?
Sir, it should be, sir, that's the same thing. It should be blocked at the level of the mid forearm, sir.
Mid forearm.
Away, when the ulnar nerve is getting away from the artery, we'll go and
So
block at that time.
it is roughly at the upper 1/4 of the forearm, right?
Yes.
But
Yes, sir.
never go at the level of the medial epicondyle, because if you inject drug there are chances that nerve will be compressed between drug and the bone. So there are higher
Yes.
chances of the nerve injury. Where will you block the radial nerve?
Sir, it is above the elbow before it is bifurcating into the
Very
superficial
good.
as well as the deep branches.
Very good. Excellent. So what is the cutaneous innervation of the forearm? Is it supplied by radial, median, and ulnar, or something else?
Sir, all the three nerves, sir.
Yeah.
Cutaneous
Forearm.
innervation.
Yeah, forearm.
Okay,
Which nerve
forearm.
supplied? Yeah, forearm. Suppose I have given radial, ulnar, and median nerve block at the mid arm level, and I want to do radius surgery or any ulnar surgery, surgery of ulnar. Will be patient have pain or not at the time of incision? You can open the again dermatome
Yes, sir.
slide.
Sir. Median cutaneous nerve of the arm and the median cutaneous nerve of the forearm. They are the major nerves which are supplying the forearm,
Yeah.
sir. So,
And lateral part is supplied by
lat,
that is lateral cutaneous nerve of forearm, that is branch of musculocutaneous nerve.
musculocutaneous nerve.
Posterior part is supplied by
Radial now.
Radial.
nerve, right? So you have to be
Yes.
careful. You should know the anatomy. You should know the
Yes, sir.
dermatome. You should know the biotome. You should know the osteotome. Otherwise, you will end up with a failed block. You have given the block very nicely, but you don't know about the supply of the. It is supplied by median cutaneous nerve of forearm. Surgeon will put up the incision and patient will skim. Patient will cry. patient will tell you that I have pain, and surgeon will tell you that give GA. You don't have given proper block. So you should know that you should know that I have not blocked medial cutaneous nerve foramen, which requires some local infiltration. That's it, right?
Sir,
So so, so if you know the anatomy properly, that's why this lecture is. You should know the
yes, sir.
exact anatomy. Like as I said, this area is shoulder area is supplied by supraclavicular. If you go medial, it is supplied by intercostal brachial nerve. Even if you are given brachial plexus, medial incision, there will be pain. So you have to
Pain.
give some local infiltration. When you are looking at elbow, this area is supplied by posterior cutaneous nerve of arm. Then again you have to do some local infiltration. So you should know the anatomy, then only you will have successful block, otherwise you will have a failed block. So I think this is all about brachial plexus. Any question, Neeta ma'am or anyone else?
Hello.
Yeah,
I think it's
Yeah,
quite
hello,
hello.
yes, yeah,
Yeah, Dr. Deepika here. So a
yeah,
nice
please,
presentation. So if a patient presents with a clavicle fracture, so what all
yeah,
options you have for?
yeah. So what is the nerve supply of clavicle? Then there is a question. What is the nerve supply of clavicle? Which block will you give for clavicle fracture? Vishal?
Sir, superficial cervical plexus,
Again, it is cut block or interscalene along
scut
with
or the
superficial, right? So
yes, sir.
when it is in the lateral part, it is cut block or interscalene along with the superficial cervical plexus,
Cervical plexus.
right? Anything else?
Yeah,
Just
so
two questions.
Yeah,
Yeah, please continue. I'll ask you.
hello.
yeah, please.
Yeah, so this basically, so we have also, have multiple combinations because we have done few cases of clavicle only, clavicle fracture. So clavipectoral fascia, what does exactly it
Yeah.
blocks and what
Mm.
superficial cervical plexus blocks? Will it help if you combine these blocks or you want to go with the interscalene or supraclavicular block?
Vishal, you want to answer that
Superficial.
question?
Yeah,
Clavipectoral facial pain block. Do you know about it?
yes, sir.
Ma'am, can you please answer it?
Yeah, so for that, basically, the nerve supply of clavicle becomes important. So supraclavicular nerve you have to block, which is supplied by superficial cervical plexus. If you block it, all the branches will get covered. That's a sensory innervation. Then lateral part, if fracture is in the lateral part, the lateral pectoral nerve also will have to be covered. And if you go medially, sternoclavicular joint, then you have to cover the subclavius because subclavius nerve is supplies the dorsal aspect. The ventral aspect of clavicle is covered by the suprascapular nerve. The dorsal aspect is covered by the subclavian nerve. All right. So either you go for a higher block where you block these nerves along with the superficial cervical plexus block, or second option is you block the clavipectoral. You give a clavipectoral fascia because it blocks the terminal branches of these nerves. All right. Combining it with superficial cervical, it gives a very good plane along with the sedation, and the surgeons are also very comfortable.
sometimes the clavipectoral fascia may be breached because of the clavicle fracture. So
Yeah.
it may not lie within the fascia. So you have to be very mindful about where the fracture is, how the fragments are. And if it is a clear-cut breach, you may have to deposit at two locations also. And often, even the surgeon giving an infiltration works really well, just for the sparing that occurs despite giving everything. And patient obviously has to be cooperative because it's just next to the face. So you may need to consider some sedation. You must keep in mind the options that are there without respiratory depression.
Milin, you wanted to tell something?
Neeta ma'am, I have one question. So we
Yes.
just spoke about that why we should not be giving, bilateral
Yes.
because we are like diaphragm can go and all. So my
Yes.
question is, can you give bilateral axillary nerve block if
Yes.
we have carpal tunnel? So is that okay? Because if we very mindful about how much volume we are giving bilaterally in axillary for carpal tunnel, for example. So
The-
is it
You're saying
okay?
axillary block or axillary nerve block? You're saying axillary block, right?
Axillary
For
block,
carpal
axillary block. Yeah,
carpal
not individual
carpal
nerve block.
carpal tunnel के लिए we can even go with forearm instead of blocking the whole
Individual
arm.
nerve blocks, you're saying.
Yeah, forearm
Mm.
block because in case it's bilateral. So one side an axillary may be given, other side, in fact, it can be done both sides with made forearm blocks. Because for
Okay.
carpal, so the hand becomes the motor goes, sensory goes, which is not wanted. And if you go and follow up with these patients, they are more frustrated with a paralyzed arm than
Right.
the surgery, which actually requires just analgesia more
Yeah,
than
probably could be done under just
yes, forearm,
yeah, forearm block. Yes.
forearm
Okay,
also.
thank you.
Yeah.
Dr. Prachi, actually problem is giving bilateral block in in case of shoulder surgery. So if you bilateral shoulder surgery, then you have to go for GA along with analgesic options like you can give a stud block with a very low
Yes, sir.
volume, or you if you want to do it under surgical anesthesia, you can go for initially on the one side and then on the next day on the other side. And if
Right,
you
sir.
want to provide analgesia, you can even go for costoclavicle. Even costoclavical catheters are put for shoulder surgery because drug will
Mm-hmm.
spread to the supraclavicular nerve and it will definitely block axillary and lateral pectoral nerve. So with costoclavicular block, there are reports, many reports, and many case study to provide the shoulder analgesia. So on one side you can go below clavicle, and on other side you
Yes.
can go above the clavicle.
Right. Thank you.
Dr. Milin, you wanted to tell
Yeah,
something?
hi.
Yeah.
Yeah. Question to all the fellows. What is the commonest artifact that we would see in a lateral intraclavicular block?
Reverberation artifact.
No.
Anyone?
So can you repeat the question?
What is the commonest artifact that we would see in a lateral infraclavicular fossa block?
Sir, bayonet artifact.
It's because of the axillary artery.
Okay, it is the post acoustic
Post-acoustic
enhancement of the
enhancement.
Yes.
axillary artery.
So then we would sometimes mistake it with a median cord, and then the block would not act there because of that enhancement. So we have to take care of that. And what are the common vessels that you should know and you could encounter in all the levels of the block? The interscalene block, the supraclavicular block, the intraclavicular blocks.
Yeah, that is important question.
In the interscalene block, what vessel you
Vishad,
can see?
Vishad,
So deep
Yeah.
cervical artery, uh,
hmm,
the transverse cervical artery is
huh,
there. The suprascapular
Hmm.
artery is there, sir.
hmm.
Suprascapular artery level you commonly see this level of block.
Dorsal scapular artery or
Dorsal
transverse
scale.
cervical artery.
Very good.
For the interscalene, yes.
Then it also
What about
depends on
the
the level. If it is at the C5 level, then it will be dorsal scapular artery. If it is below, then it can be transverse cervical artery.
yes? Okay, what about the intraclavicular? What vessels you can see emerging out from
So
the axillary artery?
the cephalic vein will be there. That might be going and joining the axillary vein. So we'll just have to avoid it. And the thoracoacromion vessels will be there, which are originating from the axillary artery. So we'll just have to avoid those vessels there.
As you come from the medial to the
Also
lateral
pectoral
intraclavicular,
vessels.
Yes. As you come from the medial to the lateral infraclavicular fossa, first you will see the axillary vein giving out cephalic vein, and then when you come as more lateral, there will be thoracoacromial artery branching out into two, if you can see properly, from the axillary artery.
Yes.
Okay, sir. So that's it from my side.
Yeah. Thank you, sir. Anything else? Anyone want to ask anything? I think we are done with it. So can we stop?
Yes.
Thank you, Vishad. It was a nice presentation.
Thank
But
you.
Thank you, sir.
write down the points we asked and read it. These
Yes,
are
sir.
the important questions for the exam for all the fellows. So read the things and discuss with your mentor, right?
Yes, sir.
Thank you.
Thank you, sir.
Thank you, Nita
Thank you,
ma'am.
sir.
Thank you, Hetal sir.
Thank you,
Thank you,
sir.
Milind sir.